Okay, it's 9:32. We have a good amount of people here and more to come in, but I'm just going to start with welcoming everyone and doing some announcements. So welcome to HIV Center Rounds. Thank you all for being here. Our upcoming rounds for April include on April 6th, we have two people presenting, and that will be Mirinda Kotze, talking about the role of theory in increasingly data-driven world, a systematic analysis of trends in South African HIV behavioral research, along with our very own Brian Kuttner, who will be talking about applying ontologies from the behavior change wheel to identify and develop the theoretical basis of strategies that mitigate HIV-related stigma in healthcare settings. And then our second outside speaker grand rounds in April will be Qureisha Abdul Karim, who's well known to many of us from South Africa, but also has a Columbia faculty appointment. Qureisha will be talking about HIV research during a pandemic, experiences and lessons from South Africa. So I'd like to introduce our panel for today, our speakers, on a very, very important topic that is drawing much more needed and deserved attention around people living long-term with HIV, long-term survivors, people aging with HIV. And we've got a really wonderful group here that represent a really wonderful project. Since there are several speakers, I'm going to give very, very brief introductions to each of them and turn it over to the group. And I'm just listing the people right now in alphabetical order. We have Dan Belanger, who has an MSW from Hunter College and is a graduate of the Institute for Healthcare Improvements Advisor Program. He's been the New York State HIV Quality of Care Program Director at the AIDS Institute in the New York State Department of Health since 2008. Maria Brown has a Ph.D. from Syracuse University's Maxwell School of Citizenship and Public Affairs and is an assistant research professor and a social gerontologist in the David B. Falk College of Sport and Human Dynamics. Then we have Nicole Fera, who got her master's degree in public health from University of Albany and is a program assistant coordinator for the AIDS Institute within the Center for Program Development, Implementation, Research, and Evaluation. Then we have Dr. Rebecca Glassman, a graduate of the University of Pennsylvania, got a medical degree at Tufts University, and is a primary care physician with a focus in the primary care of patients living with HIV and those at risk for HIV. And specifically at Westchester Medical Center, she's the medical director of the Ally Care Center, providing comprehensive medical care and wraparound services to patients with HIV and patients at risk for acquiring HIV. And then we have Eugenia Siegler. I have the good fortune of working with Jeannie in a HRSA SPINS initiative on HIV and aging that's going on right now with the AIDS Institute. And so I'm proud and pleased to introduce Jeannie Siegler, who is the Mason Adams Professor of Geriatric Medicine and Professor of Clinical Medicine at Weill Cornell Medicine. After receiving her undergraduate degree in biochemical sciences from Princeton, she obtained her MD from Johns Hopkins and is now an associate program director for the medical residency at the Weill Cornell campus of New York Presbyterian Hospital, where she's a teaching attending on the inpatient geriatric services and see geriatric outpatients, definitely a leader in the field in geriatric medicine. And then last but not least of who I'm introducing, another person I get to work closely with in the HRSA SPINS initiative with the AIDS Institute is John Wikiera, who is a founding member of the New York State Peer Worker Certification Review Board. He is a certified peer worker himself and also the chair of the New York Statewide Peer Network and has served for more than 25 years as an advocate at the state and local levels, using his very amazing skills as an effective educator and facilitator. And I'll just add that he also has a 20-year membership of the New York State Department of Health Quality of Care Consumer Advisory Committee, where he does chair the HIV, Aging, and Long-Term Survivors Subcommittee. Obviously, all relevant to today's topic. We have this very great, wonderful, diverse group here. And as I understand, there will be a few more people joining the panel, and they will be introduced. And so I'm going to turn it over to Dan's going to start on talking about this program, Healthcare for Older Persons Living with HIV and Long-Term Survivors. This is a consumer-driven quality improvement project. So over to you, Dan, and the rest of the group.
All right. Well, thank you very much, Robert, for that wonderful introduction. And yeah, it is really great to be here with this really lovely group of presenters to talk to you about the AIDS Institute's really collaborative, consumer-driven quality improvement project to improve care and outcomes for older people with HIV and long-term survivors of HIV. So we could go to the next slide, Nicole. So why did we choose the topic? Well, almost 1% of people in New York State over the age of 55 as of 2020 are HIV positive. 56.6% of people with HIV in New York State are over the age of 50, and also in New York City the same. And more than 28% in both the city and the state are over the age of 60. We could go to the next slide. So first off, I'm going to give you just sort of a sweeping overview of, of the project, which actually started in 2019. But to start off with, I want to take a step back and just tell you about the AIDS Institute Quality of Care Program. So at the Quality of Care Program, we focus on improving care and outcomes for people living with HIV across New York State. We have two advisory committees that recommend where we should put our attentions. We have the Quality Advisory Committee, which is made up of medical providers from around the state, and the Consumer Advisory Committee made up of consumers from around the state. So in 2019, the Consumer Advisory Committee, after a presentation by Dr. Siegler, I believe, took up the mantle of really focusing on how we can improve care and outcomes for people aging with HIV and long-term survivors. And so they spoke with the Quality Advisory Committee, who agreed that this was important, and so they formed a subcommittee. They called some town halls, inviting providers and consumers and public health practitioners from around the state. It was decided that a survey would be developed, and that's where Maria Brown, another presenter of ours today from Syracuse University, helped us to put together the survey. When the results came in, we reconvened the town halls and used some quality improvement tools to structure the discussion on how we could use the results to improve care. It was decided that a screening process would take place to understand the needs of particular patients so the providers could respond to those needs. And so I'm going to hand off now to my colleague, John Wikiera, and then after John, Maria Brown will speak to fill in the details on some of what I just said. John.
Thank you, Dan. So, as Dan said, we started out some time ago, and if you take a look at the timeline here for our project, we started in September of 2019. It was our CAC meeting where Dr. Siegler came and did a lecture on aging with HIV. It was a very eye-opening lecture. There were some items that Jeannie talked about that I never heard before. And frankly, I was surprised, and I thought, wow, this is really something that we need to continue talking about. March of 2020, we established the Aging and Long-Term Survivors and Perinatally Diagnosed Subcommittee of the CAC. In August of 2020, as Dan said, we started holding some town hall meetings, and Dr. Brown helped us to develop a survey. Those town halls had people included from all across the state: consumers, providers, government, state workers, academics. It was such a diverse community. It was wonderful, and we had a really good, feedback from especially the people who are living with HIV to help guide us in what the survey was going to say. So Should I continue with that, or is that the next slide after that one?
You could go to the next slide, John.
Okay,
There you
that's I always thought so. Thanks. So in August, we, like I said, held town halls. Participants were asked to list barriers and suggestions to improve quality of care for healthcare and support services. So we sent out invitations across the state, as I said. The first town halls included small group discussions. We had breakout groups to identify quality of care issues encountered in healthcare. The second town hall, we explored quality of care issues encountered in support services. And then participants in breakout groups were asked about problems they personally had encountered and recommendations. What recommendations did they have for change? Next slide. So we created a team to develop, post and analyze the survey based on the responses. There was clinical care and coordination, telehealth and telemedicine, transportation and food, aging and long-term care, COVID-19, housing, mental health and social support, medication and pharmacy, health equity and stigma, and financial support. And I think the next slide goes to Maria, is that right?
Yep, that's right.
Okay.
So after we designed this survey, we fielded the survey in June of 2021. And I do want to say that the team was composed of the HALP co-chairs, and that everybody had an equal part in determining the contents of the survey. But I fielded it through Syracuse University survey site. We distributed it for 2 months, and we started presenting the surveys in September. Do you want to go to the next slide? So we presented the surveys to the subcommittee in September, to CAC and QAC, and then to other advisory groups around the state, and to multiple individuals and groups within AI. And then, so these are some of the results of the survey. So the survey was responded to by 124 consumers and 44 providers or clinicians. The consumers were older than the clinicians on average. We had broad representation from across the state, although we do have to always include the caveat that we did not hear from as many rural, perinatally diagnosed, or trans non-binary consumers as we had hoped to hear from. The consumers are different in terms of the racial distribution of that group compared to the provider clinician sample, which echoed some of the feedback consumers gave about the lack of diversity among providers, and the providers, particularly in mental health services, not being representative of the consumer population that they serve. I always feel like that's important to mention. Next slide, please. You can see here that on average, consumers have been living with their HIV or AIDS diagnosis for about 27 years. Some of those over 50 were newly diagnosed, as shown at the lower end of the range of 3 years. And some of them were diagnosed in the 80s, when most newly diagnosed folks back then were diagnosed with AIDS, and many were dying relatively soon after being diagnosed. So we have some very long-term survivors in our consumer base. Next slide, please. So this example shows what the consumers prioritized as relevant barriers and recommendations in the clinical care and coordination category of the survey. The responses from providers and clinicians were very similar to those from consumers, so we just focused on the consumers. They identified the lack of care coordination as a barrier, and they identified 3 changes that could improve care coordination, one being providing clinicians with relevant experience, for example, training, to help consumers manage their complex care needs. And then you're going to see as we go through this presentation that the pilot we're talking about today addresses this recommendation specifically, and that you'll see that in the for future slides. And I think that that's all you have to hear from me. So Dan, take it away.
Great. All righty. Thanks, Maria. Great. So as mentioned earlier, the next step, the town halls were reconvened, and some quality improvement tools were used to structure the discussion on how best to use these results that Maria just told us about to improve care and outcomes for people aging with HIV and long-term survivors. And so we could go to the next slide. So one of the QI tools, and one of my favorite QI tools that was used, was the driver diagram, which is, it's really a dynamic tool that helps you to strategize improvements based on the most important drivers of how to get there. And so on the far left-hand side, you see the primary outcome, which is the goal to improve care and outcomes for the population. And then you have a list of the primary drivers. These are the big factors, the main things that we think will really make a difference and get us to the outcome we're looking for. Now, we took these, the primary drivers were the areas that Maria was just mentioning that came from the survey that folks felt were most important to improve care and outcomes. And then so the secondary drivers are really subsets of the primary drivers, and they're so smaller chunks, areas that you can actually focus on and make improvements in. And so this was these ideas were discussed by the group, and you can see things like education for providers, education for consumers, stigma reduction activities, and then one of the key factors, I should say we added an extra column also, you don't usually see in a driver diagram, to talk about quality improvement activities based on the secondary drivers. And I think if we hit the click, there we go, we can see that one of the key areas here was to actually use a screening, an annual screening to help providers to focus in on areas of need. And so to talk more about the screening, I'm going to hand it off to Dr. Siegler. Eugenia.
Thank you, Dan. As you saw, that there were 10 topic areas, and within each topic area, so many different ideas about what could be improved, There was a general consensus, though, to try with screening as our first QI initiative, and so we elected to adapt the World Health Organization ICOPE screening tool, and I wanted to spend a little bit of time explaining that to you. Next slide, please. ICOPE, the World Health Organization ICOPE stands for Integrated Care for Older People, and it is a general primary care approach to aging. So the World Health Organization defines healthy aging as developing and maintaining the functional ability that fosters well-being. And this guidance, which I'm happy to send out to people if they want to look at it further. This guidance I learned about from Giovanni Giraldi, who's a leader in HIV and aging, internationally known leader in HIV and aging. And I like the conceptual framework behind it. And of course, the imprimatur of World Health Organization allowed us to use a scale that already had been developed. So on the right-hand side of the slide are depictions of two very important concepts. And the first is intrinsic capacity. And World Health Organization defines intrinsic capacity as the combination of the individual's physical and mental, including psychological capacities. So and if you look at sort of the salmon colors there, an individual may begin with a high and very stable capacity, and over time may have a beginning of decline, in which case health services may be arranged to try to prevent that decline. If the decline continues further, health services are there to manage chronic conditions. The other point that's brought up is the so-called difference between intrinsic capacity and functional ability. And functional ability is defined as the combination, an interaction of intrinsic capacity with the environment that a person habits. And so I love this conceptual framework because it recognizes and insists upon the importance of shaping the environment to help people function at their maximal ability. And that's the sort of blue areas there. We cannot view this entirely through a medical prism. How to give people the best quality of life and well-being requires that we change our environment, change how we do things to allow people to function maximally. So that sort of underpins the concept. And then they had developed a screening tool that identified the 6 key domains of intrinsic capacity. And those are there on the left. Most are obvious. Vitality is nutrition, but vision, hearing, cognition, emotional health, ability, locomotion, these are considered the key domains. And these are, of course, the domains that we adapted for measurement. So next slide, please. So this is the tool, and it's online at the AIDS Institute website, and it is very simply modified from the initial ICOPE tool. We made several adjustments. First of all, we changed the name of the domains back to a positive framework, so that instead of cognitive decline, we said memory, and we also added some screening methods so that the tool could be administered either in person or by phone or video. So for example, if you look at mobility, in person, the initial screen was having someone stand up from a chair without using their arms 5 times. And we recognized we could not ask someone to do this if we weren't present. So instead we had options for asking questions in addition to visualizing mobility or investigating hearing in person. We added a question. Again, this was based on recommendations from our subcommittee. We added a question to the nutrition section about whether people had physical difficulty eating. And we made sure that this screening tool could be administered by staff or peer workers in person or virtually. So Dan, back to you in terms of the time.
Okay. Oh, great, Jeannie. So thanks very much. So I'm going to just describe a little bit about the screening pilot that we put together. So one thing, this is the ICOPE tool we used with long-term survivors, who we defined as people who were HIV positive for 15 years or more, as well as those aging, we described as 50 years or older. And those perinatally diagnosed were also could be part of the screening. So I think key to the success of the screening pilot was that we were very flexible on timeframes and things, given COVID and the strain on resources at the time. So the pilot was from August 1st to November 15th, but we allowed sites to participate for any 8 weeks within that time frame. So we didn't say it had to be any specific 8 weeks, but any 8 weeks they would participate. And so what we asked was that someone would administer the screen, and as Jeannie said, there were many different ways that this could be done. In some cases it was a case manager, in some cases a peer, a nurse, or the actual medical provider. Asked that the screening be done before the provider sees the patient, so that the provider has the completed screening tool in front of them when they see the patient, so they can see if there's extra support needed, including linkages and things like that. So we asked that they look at 2 4-week increments, and that they aggregate their data, their outcomes, after each 4-week increment to look at trends in outcomes, to see what was happening, to see if there were any process changes that they could make to their clinic or their program to better serve the patients. So just give you a quick, for instance, if there were 30% of the patients you saw in that 4-week period had issues with vision, you might consider changing your signage, changing your education materials, changing prescription labels. And so one other, I think key aspect was that we had a learning group that met on a monthly basis where the providers could discuss the challenges and successes. And now we could go to the next slide. Okay, great. And so we had 14 providers, or 4 supportive service CBOs, and 10 clinical providers, medical providers from around the state. There were, quite a few in the greater metropolitan area, but also across other regions. And 13 of the 14 providers submitted data. So that's all for supportive service, and 9 of the 10 clinical providers. And next slide. And so here we can hand off to my colleague, Nicole Fera from the AIDS Institute, who's going to tell us a little bit more about the data outcomes.
Thanks, Dan. So like Dan mentioned, we'll now get into some of the results of the pilot. And as Dan previously mentioned as well, sites were asked to submit data in 2 rounds. So the first round being the first 4 weeks of data, and the second round being the second 4 weeks of data. And again, after the site submitted their 4 weeks of data, we conducted learning sessions with them to learn about their experience through the first 4 weeks and make adjustments to how data was submitted, how data was collected, and any other feedback that they had on the screening tool that they were using. So out of the 14 sites that participated, 13 submitted data. So the following figures and tables show the combined data for the 13 sites for the full 8 weeks of the pilot. So this figure shows the eligible and screened participants based on patient category. So the x-axis depicts the patient categories, those people under 50 or long-term survivors, and those people 50 and older. And the y-axis shows the number of people. So the blue portion of the bar shows the number of people who were eligible and who were screened. And the orange portion shows the number of people who were eligible and not screened. So then the whole bar adds up to the total number of eligible patients. So prior to the start of the pilot, we met with each site individually to talk with them about how they would determine eligibility and how they would reach these eligible patients to conduct the screening. And sites kind of each had their own way of identifying and carrying out the screening with the eligible patients. Some used cascade data to find patients who were 50 plus and or long-term survivors, and then kind of looked at their schedules to see patients who were coming into the clinic during the pilot period to actually do the screening while they were in the clinic. And then some sites also used their case managers who referred eligible patients to the providers or the registered nurses or social workers to conduct the screening. So we can see that total, about 1/3 of all eligible patients were screened. So this may not seem like very much. However, the pilot only lasted 8 weeks. So this meant that participating sites were able to screen over 1/3 of their patients within this 8-week time frame. So they were really able to screen a significant amount of patients in this short time frame, and may be able to screen all patients within a year or even less. So just to keep that in mind. So then this figure shows the eligible and screened participants based on participant category. So the x-axis depicts the categories. Oh, sorry, no, this figure looks at people screened and then referred for services. So on the x-axis, we have the topic area for screening, such as memory, mobility, nutrition, vision, hearing, and mood. And the y-axis contains the number of people. And just a quick note, the categories were not mutually exclusive, meaning one patient could have screened as having a need in more than one topic area, but they were still considered one number of persons screened. So the green bar shows how many people were screened as having a need in that topic area. For example, when we look at memory, The green bar shows 180 people showed a need in memory, which was 28% of all people screened. And then the red bar shows the number of people showing a need in the topic area that also had a referral made. So again, for memory, we see that 19 people were referred to memory services who were screened with a memory need, which was 11% of those screened for memory needs. And then as a side note, there were different reasons why a referral wasn't made, which included a patient was already linked to the needed care, or they refused to utilize the referral. So in this graph, we kind of see that vision and mood showed the highest need. We also see that vision showed the most referrals made, with 74 or 24% of positive screens. And then we also look at hearing, we can see that it showed the highest percent of referral made in relation to all those who screened positive. So 27% of those with positive screens had a completed referral. So overall, there were a good amount of referrals and linkages made. We also wanted to note that these screens also led to many additional patients being helped because sites made process changes in their clinics when looking at how many patients identified additional needs from this screening, which I'll talk about a little more about on the next slide. So on this slide, we see some of the process changes that sites made based on the results of their screenings. And the table includes the topic area, the number of sites out of 13 who made a process change in each area, and then an example of a process change that was made. So we can see that nutrition was a topic area where many organizations made a process change, 9 out of 13, as well as mobility with 8 out of 13 organizations making a process change. So for nutrition, an example of a process change that was made was improved linkages to a nutritionist. And then an example of a process change made for mobility was transportation assistance to and from the clinic. So on this slide, we're looking at the percent of people with an identified need in each area by individual organization. And there's a lot to digest. So on the x-axis are all the topic areas again, and on the y-axis is the percent of people. So each colored bar represents one organization. For example, if you direct your attention to the black bar, this represents one organization in each of the topic areas. So that black bar is the same organization for memory as the black bar is the same for mobility, etc. So when we look at the black bar, this represents organization 5. And if we look at the black bar for each of the topic areas, we can kind of get an idea of the percent of people with needs in each of the 6 topic areas. So the highest percentage of the black bar, people showed the highest need in mobility, as well as in memory. So we can kind of see that the needs vary across organizations, across the different topic areas. And we can also see that some areas show greater need in general, such as when we look at vision, we see a lot of the organizations have high percentages of patients with needs in that area. And the same goes for mobility. So this slide is kind of the same idea, but it looks at the sites in 2 categories of clinical and non-clinical community-based organizations rather than by individual organization. So again, on the x-axis are the topic areas, and then on the y-axis is the percent of people. So clinical sites are represented by the yellow bars, and non-clinical community-based organizations are represented by the purple bars. So again, we see that needs vary between these 2 groups. However, we still see that there are high needs in vision, mobility, and mood. So when we're looking at these categories, we see 24% for non-clinical CBOs, 24% of patients identified with this need, and 16% of clinical. And then for mood, we see both 19% for clinical and non-clinical community-based organizations had patients identifying for needs with mood. And then another thing to note is that we really see that non-clinical sites are able to attain a lot of information about their patient needs, which is really great to see. So now I'll turn it back to Dan to talk about some lessons learned.
Okay, wonderful. Thank you, Nicole. And so we paused after the first 4 weeks to hear from providers on ways that we could improve the screening pilot process. And so we found that we needed to communicate more clearly on how to complete the template. And one of the key areas was on process changes. We really had asked them if they had completed a process change, but we didn't really ask them if a process change need was indicated. So we didn't kind of break that down. So we took their advice and made changes, after the first 4 weeks for the next 4 weeks of reporting. And we could go to the next slide. And so we got lots of positive feedback from the providers. In fact, it was all positive, really. I mean, we got some wonderful ideas on how to improve the screening tool itself or the process. But all the providers basically said that they found it to be really efficient, really timely, and it added very important information. The average time it took to do the screen itself with the patient was 7 to 10 minutes. Some it was quicker, some purposefully took a lot more time. We had, for instance, had a social worker who wanted to use it to really delve down much more deeply, into the various issues from a supportive service organization. And then they had some recommendations for how we could improve the process. And one thing was to kind of write a guide on how to use the screening tool. So we're actually in the process of doing that right now. And so I now will hand off to, I'm not sure if our colleague Marz Albarran was able to join us. Marz, are you here?
I am here.
Wonderful.
Can you all hear me?
Yes.
All right. Hello, everyone. So I am co-chair of this committee, but I had the privilege of not only being on the back end of helping kind of create this, but then I was on the receiving end as well, being a patient myself. And so when I had the survey done, I went into the office for like my annual visit and they used it, and I waited until the end. I waited until they were done with it to let them know like it was really interesting and awesome to be a part of it because I was on the back end of the creating of it. But even, in me having taken the survey, there was an answer or two that was a no, that then, the social worker who was working with me, then made a note and said, okay, we'll talk to the doctor about that. So it really, I could see already how it would initiate conversations about things that we might not think about. Because like when you go to the doctor, at least for me, typically they're thinking about your whole, they're thinking about just your health, right? Whereas someone with HIV, we're an entire person, right? We have mental health, physical health, emotional health. We have, hearing issues, vision issues, stuff like that. And so I felt like this, we encompassed a lot of different things in this so that those medical facilities could help get more referrals out for those other things that maybe aren't asked about typically when you're at your medical appointment. So it was a really, really good experience. And it's super awesome to kind of have heard the positive feedback that came from it. And so I really, really hope that, we can get this implemented on a bigger level. But it was really, really pretty awesome to be part of creating it. And then on the receiving end, I do think that it will truly, truly help clinics, kind of really build their quality of care as well as awareness for maybe what needs improving.
Thank you so much, Marz. You were definitely a key part of this whole process, and so glad you were able to make it for the presentation. So next, we're going to hand off to Dr. Rebecca Glassman to give us the provider perspective. Dr. Glassman.
Yes, thanks so much for the opportunity to speak today. And it really was a privilege to participate in such an important pilot. So thank you to everybody who has presented so far for all of your hard, thoughtful work and for allowing us to participate. Our clinic has a third of our patient population is over the age of 50. So we had a lot of patients that could potentially benefit from participating in the ICOPE. We found that for the structure of our clinic that we wanted the providers actually to conduct the ICOPE screen, just because the information that we were going to gain was something that we wanted to be able to be attuned to and to make immediate recommendations and further discussion on for our patients. And I think to the credit of the ICOPE, it was incredibly easy to incorporate this into a medical visit. And it didn't take up a significant amount of time nor feel onerous. There were a couple of scenarios in which I had an additional learner trainee with me and would sometimes have the trainee conduct the ICOPE screen, maybe if there was additional patients waiting, and then we would circle back to discuss it. We had a volunteer with us who one day made some phone calls to patients who were not going to be coming in during that 2-month period. And so we wanted to make sure that we captured them. They were patients that had been seen just prior to the initiation of the pilot. So we thought this would be a nice way to capture them. But for the most part, it was the providers. We made a couple of small adjustments to the ICOPE just as we were going through, but overall found it, as I said, really easy to use. One thing that we realized is that and that's definitely I forgot to ask the recall at 5 minutes. So I failed the memory screen most of the time. And so what I did was I actually moved the question recalls all 3 words to below the hearing question on the form so that it triggered us all to remember to ask it. And then the other thing that we noticed was that durable medical equipment is a tough word for patients to understand. And so we really asked more questions about, would it be helpful for you to have any equipment in the home to help you with your mobility? And that felt like a question that patients were able to grasp onto more than using the term durable medical equipment. Something that Marz was saying really triggered with me, and when I was driving in today, I was thinking about this. In surgery, we talk a lot about the pre-surgical timeout. And what I found that this ICOPE screening tool was such an important timeout for the medical visit, to really restructure the frame of what the purpose of the visit was away from the heavy medical components to the psychosocial. And I thought it was such an important thing for all of us as providers to be doing, and we learned so much about our patients. I found the nutrition, vision, hearing answers to be the easiest to provide referrals to, and also the things that I wasn't so surprised to hear for most patients. What we found was that the vast majority of our patients were having issues with memory and having low mood. And so those were the things where we really needed to be thoughtful about process change and where we have worked to make improvements. As far as the memory goes, we have now been contracted with New York Medical College speech and language pathology students, and they're going to be leading a memory skills building group for our patients. And so for any patients that we've identified through this process and ongoing, because we're continuing to use the ICOPE tool with all of our patients over 50, they will be offered the opportunity to join the memory skills building group. I also anticipate that this will be addressing some of the mood issues that our patients brought up around isolation and lack of community. And we're hoping that this serves as a version of a peer support group in addition to providing some real skills around memory building. And we're actually hoping that as part of this memory skills group, that the participants can start to work on memoirs, which I think will be a really beautiful carry away piece for our long-term survivors aging with HIV. We're also making a lot of changes in how we get durable medical equipment. So we've been really working hard. My case manager, Eileen Hagan, is an incredible human and has found some really unique ways to get durable medical equipment for our patients. So I think those were the biggest things that we're taking away. And then lastly, our licensed mental health counselor is working with our patients who have identified mood issues to sort of prepare them for participating in therapy moving forward. And so this is sort of a brief intervention as a stepping off point to connecting them to mental health, since we have limited mental health resources And as we're preparing them, seeing what our licensed mental health counselor can achieve in a short period of time for our patients.
Thank you very much, Dr. Glassman. So now we're going to hand back off to Dr. Siegler.
Thank you as well, Dr. Glassman. This project went better than I could have dreamed, and it went because one, the number of sites that participated and the reach we had was wonderful, but also just hearing from participants and hearing from providers, both from community-based organizations and clinical sites, how they wanted to keep using it. And I think that's probably the number one proof that this was effective is that this was a pilot, but the sites that are using it liked it and are continuing to use it. And from that perspective, I couldn't be happier. So I think it was a quite successful, and it was also a huge learning opportunity for me, as well as a lot of fun, because the collaboration itself, the opportunity to learn about community-based participatory research or community-based participatory projects is something I think we aspire to more than do, and having everybody be part of this was really what made it very, very special to me. So it was successful in the very limited framework of we piloted something, people used it, people identified problems, people made changes, but that broader sense of process made it personally quite a success, as well as professionally, I think very successful. So the next mission is to get this rolling statewide, and I'm going to leave it to John to talk about where we are.
Thank you, Jeannie. So where we're at this time, the Consumer Advisory Committee, we approved the recommendation that Jeannie and I suggested. So there's a proposal for AI to consider, the recommendation. Well, it goes from the CAC to the QAC, to the Clinician Committee. And they are in the process of reviewing it. Once they put their stamp of approval on it, then it will go through AIDS Institute, Aging Department. It'll go through other administrative departments for approval. And once that happens, then a plan will be made that how is it going to be rolled out across the state. So there's a few more steps left, but I think we all feel we got the hardest part is done. And, with champions like Dr. Glassman in the field, with all the work that they did and are doing, it's amazing that, with an 8-week pilot, there was already process changes being made. So this committee, aging committee, subcommittee, is nowhere near done. We're kind of putting the finishing touches on this particular project, but we will be taking on additional projects such as probably or possibly bone health, maybe heart health, different things that we learned, as Jeannie mentioned a couple of times about dental health. So there's other topics that we're going to take up and see what we can do about trying to make some process changes. And that phrase should stick with everybody that's trying to do this work. Process changes. Number one, Dan Belanger would be very proud of you if you use that term more. And number two, it's a great way of reminding yourself that we have to keep striving to make quality improvement changes, for people who are aging and for everyone receiving services, HIV services in New York State. Thank you.
Well, wonderful. Well stated, everybody. So back to you, Robert.
Thank you all. And I'm going to let Stephen actually monitor and chair the our discussion time. But also, I mean, maybe Stephen was going to do this, but I'll let you, Stephen, comment on the various things in the chat. But just I want to draw people's attention to the link that's in there for the archives of our HIV Center rounds, and this one will get up there within the day or so. And also, I'm going to put into the chat. I noticed that there are a number of people here who don't normally join us for HIV Center rounds, which we have usually twice a month. And we want to invite you to be on our mailing list. So I'm going to put in the name of my colleague, Tanya Reed Kim, and her email for you to, if you're interested, to just send her an email and you can join our regular mailing list for HIV Center rounds. So over to you, Stephen.
Thanks, Bob, and thank you all for a wonderful presentation of this critical work. So let's jump right into the Q&A. Some technical questions. Do you plan to publish this work, and is more research needed to validate?
So I would just say, well, first off, Dr. Brown has, a paper that has been put together and is awaiting possible publication. We definitely want to look at additional aspects of this for another paper, and we also definitely think that further research would be helpful, and particularly from the quality care program perspective. We can get back in touch at least with the clinical care providers, and we do collect data annually, and we ask for quality improvement projects, and we focus a lot on health equity and disparities in care. So I think we could follow up with some more looking at those issues and differences between patient populations.
Great, thanks, Dan. A question from Brandon Silkworth. What is being done to combat the quality of care for people living with HIV and aging in our more diverse communities?
Well, I can just say that we do have a number of regional groups. We have I have the privilege of facilitating the Bronx Links group, but there's also Ending the Epidemic group, and Bronx Knows from the New York City Department of Health and Mental Hygiene. And so we do convene clinical and supportive service providers to look at issues. We are right now, we're looking at access to care issues in New York Links, and we're actually kind of excited to have supportive service providers and clinical providers, much like this program, who we are hoping that will work together on a quality improvement project that will look at both education and linkage to care, but then also what happens when the patient is linked to care, bringing them to viral load suppression. So we're hoping to do that. There's also work being done in stigma reduction. We also are we have a community health center learning network where we're looking at injectable ARV medication regimens, and we're hoping that there may be some areas for improvement there in that those will help patients in those neighborhoods and areas to get virally suppressed and remain virally suppressed. And I want to just hand off to my colleagues to add their thoughts.
Yeah. John, you go ahead.
Yeah, sorry, Gene. So I just want to say too, as far as like the diversity piece of that, and we have CAC members that are in each region of New York State, and that we are a very diverse group of people, and that really is a top priority to make sure that, you know, we're reaching out to groups that feel marginalized. Jeannie, what do you have?
I may have missed, but I think it's important to mention that there's a sort of an office of HIV and aging with the AIDS Institute. John Hardigan's sort of the point person, and he is leading an initiative that's statewide. There are, I think, 10 sites that the AI is funding to improve care for people aging with HIV. So and of course, there is a New York City initiative as well. So and these initiatives are addressing not just aging, but addressing social support and reaching out to communities that need that help. So I think it's a wonderful time. There's so much interest and funding for pilot projects, for demonstration projects at a larger level that I think, and I hope in the next, within the next 5 years, we'll have much more data than we have now about what works and what doesn't work. We have a lot of ideas now. We don't have that much data about how successful they are, but between the federal, the state, and the city initiatives that are funding HIV and aging programs, I think we'll have a lot more to say with evidence about how to provide care.
If I could just add also that the AIDS Institute is now part of the Health Equity Division of the New York State Department of Health. And so health equity is really a central goal for everything we do. But I do want to acknowledge that it's a challenge. It's a big challenge, and it is something that we really always need to focus on. And so thank you for that.
Great, thank you. I think it was mentioned in your presentation that the ICOP tool is available on the AI website. Is that correct?
I just put the link in the chat.
Perfect. Thank you, Nicole. There was a request for that. Our next question comes from Karen McKinnon. She asks, in the mood category, were refusals or decline to utilize a referral offered a predominant reason people weren't referred, or were there more instances of a provider not being available? I know it's a pretty small number, just curious given the stigma associated with mental health service utilization.
So I don't think we know at this point. We'd have to look back at that again. One other reason that we didn't mention why services weren't provided, or why linkages weren't necessarily made, was there were some services were actually provided in the clinics, and so that also is one factor that could have influenced it.
Yeah, I'd just like to add, we got some of these responses as to why referrals weren't made in the learning sessions. So it wasn't actually collected data. It was just kind of feedback that we were getting from providers when they were talking about their experience.
But it does highlight the need to go back and we can always go back and ask providers about that. And I think it's an important issue.
I can speak anecdotally to our own cohort. No one declined mental health because of stigma or lack of interest in participating. I would say that many were already connected to mental health, which is integrated into our practice. And in a small subset, we developed a waiting list for our mental health team. And that's where we started to think about these brief interventions for patients. For another small subset of individuals, we identified that their mood issues were related to other things going on. So one specific example that comes to mind was that somebody was really struggling with finances. And so that was an opportunity for our case managers to step in and provide community resources to assist with access to food, access to transportation, assistance with housing. That was really the driver for that individual's mood. So I think the point being that it opened the conversation for additional things going on in each individual's life.
Great, thank you. Our next question comes from Charles Gonzalez. And John, I know you touched on it at the end of the presentation, and there's a comment in the chat that you just entered. What are the team's next steps? And there seems to be a lack of focus vis-a-vis prevention as to place folks on the road to healthy aging. Are there suggestions beyond diet and exercise?
Most certainly, yes. You know, what's interesting is we learned so much from the town halls and participants giving their input that was really our guide on what went into the survey, you know, what we focused on. And it was very interesting, you know, what people were saying. And so based on what the majority were talking about, we went in that direction. But absolutely, we want to make sure, you know, like I said, mobility, memory, you know, what are, like Jeannie, I've learned from her, she can say this better than I can, but the 5 M's, right, Jeannie? So, you know, there are several domains that we want to look at. And we also have said to like the pilot participants and others, you know, what works for you? You know, we have this screen, the screen tool is a suggestion. If you have other information that you want to try and collect or ask about, add it to your screen tool. You know, don't limit yourself to just what it says on the modified ICOPE. You know, it's a start, but you can certainly modify it for your use as well.
John, may I step in? We don't have to, but if you remember the driver diagram, there were 10 categories, and each category had suggestions, or rather had barriers and suggestions. And I think one of the unique features about this project was it wasn't just what barriers people had, but what suggestions they had. We took the lowest hanging fruit. You know, what can we do in the clinic that utilizes currently existing personnel and yet addresses a need that people perceive. There are many preventive measures that could be taken, focusing on housing, reducing loneliness. There are so many social determinants of health that need to be addressed, and if addressed, especially after COVID, could improve health. We have seen socialization measures in some of the programs truly helping people with lived experience. The problem is, where's the money going to come from? And even if it's part of a demonstration project, how's it going to be paid for once the project's over? So I think that every single category had recommendations. We didn't even address the social services part of the town halls. We just took one thing and had a successful QI project of one idea in one category. And I would say all of those things would help individuals' health. It's a matter of getting resources to organizations so that they can do them. And any opportunities we'll jump on.
Great, thank you. John, it looks like you responded to one of our last questions, but I'll just read it out to the group. And Rebecca touched on this a little bit. I'm curious if the screener brought to light other social needs, such as insurance, housing instability, food insecurity, elder abuse, or violence. Also wondering how many organizations were in New York City metro area, and if there were any unique challenges these organizations face. And John wrote, yes, we did get support services needs input, and we are making sure those who take care of those at DOH are addressing those needs.
Yeah, and I'm not sure what the data showed. Maybe Maria would know on, you know, the sites in or participants of the survey in New York City. I don't remember that.
Right. I don't remember exactly, but I think it was something along the lines of 7 or 8 of them were in New York City. And I know we had Westchester represented, Dr. Glassman, and we did have representation from counties upstate. Nicole, do you know exactly the number?
For the pilot sites,
Yeah, in New York City.
8 in New York City, and then 9 if you count Westchester.
Okay. Honorary New York City. Okay.
And would you say these New York City sites had any unique challenges to them?
So we didn't actually look at this, but that would be interesting to analyze.
Well, yeah, I mean, I think some of the discussions in the learning groups did highlight different approaches and some different challenges. And I know, for instance, one of the sites one of the sites in Queens really used the screening tool to delve down very deeply. A social worker used it to look at some of the things that you just mentioned, more deeply, and to respond to that. So yes, I definitely think there were unique ways that this pilot was instituted at different sites, and I think there were unique challenges as well.
Great. And Teo, I believe you have a question.
Yes. Well, first of all, I want to say what a wonderful presentation. So many people who spoke, and you could have used more time. That's great. It's amazing. And so many different things that you highlighted. And it's really fascinating to see how a group like yours is be able to work together. The question that I had is something that concerns me, or that I'm dealing with as well, is you're asking clinics to do maybe not an awful lot, but some more work than they usually do. How did clinics deal with that? I assume that you didn't have any incentives. Of course, it was all for the patients, and everybody thinks it's important, but that does not necessarily mean that there is time and energy to do these things. So I'm curious whether there was any pushback or compensation or something that the clinics got out of it.
I don't know if Rebecca, you wanted to comment from Westchester perspective?
She might have had to step away.
No worries. I just generally say that yes, we were delighted to help, that so many providers and were interested in participating, and I think that we just like a lot of awareness and a lot of passion for this issue. And it is kind of amazing. We do a lot of quality improvement projects, and it is amazing that what providers are willing and able to do. We did try to keep it, like I said earlier, very flexible on the reporting period, and then we wanted to use screening that was brief. It was quite brief. So because we definitely were very aware that we didn't want to put like a lot of burden on the providers. So I think that helped, and I do think having Jeannie and John and Marz, having a good group of consumers and providers, and Dr. Glassman kind of really speaking up for this and saying how important it is was really key to making it happen as well.
I'll add something just briefly. Once you obviously have a biased sample here. These are the people who volunteered to do it, and
Yes.
so in that sense, they agreed to do something and did a wonderful job. You're describing what is the biggest hurdle now, and how do you, and one of the reasons why we are very interested in seeing this as a standard of care across the state. And again, it makes sense. You have to go beyond viral load to to help people cope with the next set of years of their lives. What I will say is, again, in addition to brevity, the deliberate use of non-physician personnel including peer workers, to do the survey, I think it offers sites an opportunity to work it into the workflow. And then the challenge just becomes, how do we get the information to the clinician? So what you're describing is, of course, what even for this one small project, what is not going to be an easy goal, which is how do you move from a pilot to saying this is something that should be done statewide, and we're not there yet. We're edging close to it, but we're not there yet. We're trying to make it as useful and friendly as possible.
I think one of the things we have to keep in mind is aligning this work with other work that's being done at the AIDS Institute around aging. We have, like Jeannie had mentioned, John Hartigan, who has a pilot going on now to look at innovative ways to improve care and services. And then there's also a national pilot with Clemens Steinbach, who's has the same focus. So I think aligning this with those with the work that they're doing is also will be something that we'll want to keep in mind as we move forward.
Can I just add one thing, and that's that people in academia have been researching the HIV and aging with HIV phenomenon for a long time, but not a lot of that has been translated into changes in clinical practice. And so one of the goals of this survey was not just to find out what is not working, but to hear from consumers themselves and providers about what they think would work better. So to me, it wasn't that much of a surprise that 14 sites volunteered, because I think if you're working, I mean, I can't speak for a clinician because I'm not a clinician, but if you're working with people with HIV who are aging and you're reading in the journals all the time about all the problems that they're facing, you might be like more than ready for something you can implement in your own practice that can start to address the problems you've been seeing in front of you and you've been reading about in the literature. So I think that might have contributed to the popularity of the pilot.
John, did you have something to add?
Yeah, thank you. So one of somebody asked earlier, what are some of the other things that came out of this work? And one thing was we heard a lot was we need to utilize certified peer workers or peer workers. We in New York State, I'm a certified peer worker. I was on the original board, advisory board, and there's over 250 certified peer workers in New York State. There's a training that's being developed that will enable peer workers to conduct screenings. This is hugely important. This is really a big, it's not, where that's not part of the clinical and quality improvement piece, but it's something that came out of this work. And so we really made sure that we spoke loudly about that. People felt, my peers and colleagues felt very strongly that peer workers need to be involved more. And so it's happening. It's the, Department of Health listened, AIDS Institute listened, everybody's working on pieces of this, and it's not just one department, it's many departments. So it's truly a project that, like I say, it blossomed and it went in different directions, and that's wonderful. That's a wonderful thing.
Like, I see you're back. I don't know if you wanted to add anything.
Can I ask Stephen an expanded question on that? Because Jeannie brought it up, and then I'm thinking about Teo's question and what John just said. I'm just wondering, and as I commented in my introduction, I think the peer worker program New York State has is fantastic. I'm just wondering how much it is or isn't utilized, or how much this program has brought it to the attention of the sites you work with. Did they have peer support workers and on staff, or did this introduce it to them? I guess what I'm asking is are there barriers, or are there reasons why some sites don't have peer workers? And I believe it should be a well-paid position on a team in any kind of clinic. And so I'm just any insights as to what some of those barriers are, or if this program actually helped make that happen in some of your sites.
Robert, I want to answer a little bit to that. I think that's an excellent question. That is something that we advocate still, that peer workers who are doing this, with 20 or 30 years of lived experience, plus all the education and different things that they've gone through, they're highly valuable in this work. There were peer workers before we started this, and the term is interchangeable with health navigators, community health workers. Excuse me. There's many different names or descriptions how agency to agency, but one of the things too is that a certified peer worker is recognized by the Department of Health AIDS Institute as a professionally trained peer. And that's not to take away from anybody else. It's just to say that we've gone through the required classes and done practicums, and then we were able to, become a certified peer worker. But I think one of the biggest challenges that we face is trying to get more peer workers in different agencies, and asking the agencies to say, hey, you really should have peer workers on your quality improvement committee. You really should have peer workers on your advisory committees. There's many different avenues where they can give input. So it's a challenge. I think it's getting better, but it needs to be a lot better than what it is.
Thank you, John.
We have another question from Karen McKinnon. Your mood questions are basically the PHQ-2, but without the frequency scale. Did folks who answered yes to any of the questions, including the loneliness or isolation question, get formally screened with the PHQ-2 or 9 as part of their next steps towards referral or care?
I know that in some cases they did, yes. I think it did vary from site to site, but I think, I know, Rebecca, did you want to comment on that?
Yes, in our practice, in addition to the ICOPE, every patient coming in gets a PHQ-2, and if either question is positive, then it flags to a PHQ-9, and that's just standard of care for everybody walking in our door. So in addition to those questions being asked in the ICOPE, they were also addressed by the intake team at the time they walked in.
Great. Fran, you have a question?
I have to unmute myself. Can you hear me?
Yes.
Yes.
So I just want to say I was at a presentation this week where someone from the State Office of Mental Health, Tom Smith, the medical director, made a comment about the fact that, the State Office of Mental Health is trying to be able to use people who don't have professional degrees to do some interventions that are, in the mental health area. And there's a lot of resistance from those who are licensed professionals within mental health. So, all the people like me, right? There's like psychiatrists, the psychologists, and those of us who've done some work in Africa know that task shifting and sharing is common there. But bringing it back here creates a lot of issues about scope of practice and licensing. And I don't know if you're collaborating at all with the New York State Office of Mental Health, but they're trying to, they avoid HIV like the plague on the one hand, but on the other hand, they really are trying to figure out how do we get a workforce that can allow people who don't have the highest level of training to be good collaborators and deliver some of the services. And we know from COVID, we'll never have enough professional providers to do all the work that needs to be done. We know the value of, task sharing. And I'm just thinking that it's a shame that they never participate because they're facing the same issue. So I was just wondering if you want to comment.
Can I just say, we did definitely, Fran, we did hear some of those concerns and from providers. And in some of our meetings with the programs, some questions came up, like if there was a mental health crisis or something while doing the screening, what do we do? And, providers had, some direction for that, and we definitely directed that the screening is a screening, and that any additional questions need to go to the medical provider or the healthcare team. And we do think that in writing the guidance, I think that will be helpful in including some of that, and I do think I'm not sure, John, in the peer program, how in the aging tract, if some of that's being discussed as well.
Yeah, it's a good question, Dan. So all of the points that we touched on, through our work, the development of the training is following that. So it's the training will mention all those domains and talk about that. And also just to mention, the CAC does have a subcommittee that is addressing mental health and substance use disorder. On the quality committee.
So can I make one other comment about this? One of the things, so since I'm one of the people here who's done some work in sub-Saharan Africa, and I really learned a lot when I came back here, and then COVID hit. Because it's very clear that there was a very high level of distress among healthcare workers and patients. And clearly not a behavioral health workforce to deal with it. And if we're going to ever meet on the mood, the mental health, loneliness, all of that, if we're ever going to meet that set of needs, we're going to need to use people who aren't psychiatrists, psychologists, social workers, whatever. We're going to really need to use that group. So I guess my comment is more about how to be more effective in fighting all those scope of practice issues. Somebody was presenting in one of the presentations I went to on a strategy that they used. I think it was in another state, to try to work with professional organizations to get them to see the value of extenders for their work and of collaboration. And I just wonder if that's just a big issue that we need as much savvy as possible to make it, feasible for people to do work who aren't in a licensed profession. There's nothing wrong with licensed people, mind you, or.
Yeah.
Absolutely.
Go ahead, Jeannie, sorry.
I just want to mention, John, you should comment about your support network and how that grew organically from this need. So John basically is running running an amazing peer network that started regionally, and then when COVID hit, has become it's been a statewide peer support network, and so. I think that you sometimes the battles over control are just take all the energy out, but if you rename it and you call it something different, and there are opportunities for us to create things like what John's creating. I want him to talk about it a little bit, that may provide support in ways that are non-threatening to those who demand a license.
Thanks, Jeannie. Jeannie's right. So we have a group that meets every Monday from 10:30 or from 10 until 11:30. And in the very beginning of this idea, it was a regional meeting to help network and get people together in the Central New York region, which is the second largest region in the state. COVID, hit, and a lot of people were saying, wow, we're not going to see each other in person at meetings. We're not going to be able to get together anymore. We're all feeling isolated and lonely and scared. And so we talked with AIDS Institute and said, what do you think? Is this something that we could expand across the state to help alleviate, some of this concerns and anxiety? And said yes. So we started out with Mondays and Fridays. We were doing meetings, and during the really heavy part of COVID, 2 days were needed. And as people started going back to work and getting back into the swing of life again, we went down to one Monday. But we have speakers, we've had AETC, we've had Dr. Gonzalez from AIDS Institute, we've had Dan Belanger, we've had Jeannie, we've had many people come in and talk about all these different things that we've mentioned here today. So it's support, it's education, it's for providers, consumers. It's really a safe place to come and just say, hey, I'm feeling lonely and isolated. What do I do? We've been able to help people from the sidelines. So it's something that we will have more discussions. We helped host the town halls that we did for this project. We will do more town halls. So it really, like everybody mentioned earlier, it was a true collaboration across the state. It wasn't just any one person or one team. It was many of us. It really is a work that we can all say we're very proud of and happy the way it's turned out. And this is certainly not the end of this. We have a lot more work to do. We'll continue aging with HIV work right on, but yeah, if anybody, I'll put the Gmail address in the chat. If anybody's interested, I can send out flyers that have the Zoom link and information on how to join. We did start a once a month evening call, and those have been successful. Small amount of attendees, but a very enjoyable call. So we've done a lot of trauma-informed care educations. So there's really, coming out of this, we learned a lot, so we can tailor some of our things that we're doing with the network, in responding to this. Thank you.
I just want to add, and this is a much smaller point. I really agree with everything that Fran, John, and Jeannie just said. But also, COVID has really changed the world and has made really telehealth much more doable and done. But we really don't see it any quality improvement programs, any structure really happening very quickly, and that would involve consumers and how to better use telehealth. We do have a telehealth learning group. We have someone coming up talking about their mental health telehealth program. We've had people talk about PrEP and then talk about HIV care. So I think there is, there's also a way to involve more people without licenses in those telehealth visits as well. And I just wanted to add that.
Thanks, Dan. And thank you again to the entire team and our attendees. This was a lively discussion. I would love to continue it, but we are at time. So thank you. And Bob, I'll turn it back to you.
Right. Thank you, Stephen. Let me echo what Stephen and many have said. This was really fantastic. I think we could have used another hour of discussion. And I'm seeing that in the chat, some connections are being made. So please follow up on connections with each other. Join our HIV Center mailing list. Our next grand rounds is on April 6th. A lot of learning was done here, and I want to make one particular comment because several people asked in the chat and the Q&A. We've learned that we should be enabling our closed captioning on these webinars. So thank you for that lesson. So let's keep teaching each other and supporting each other in this important work. Take care, everyone. Be well.
Thank you.
Thank you.